Hi all, my presentation will focus on Aboriginal and Torres Strait Islander peoples with autism spectrum disorder. To begin, I'd like to read a quote from Dr. Tamara McKean, who is a Wallian woman, that explains very well the meaning and understanding of health for Indigenous populations. To us, health is about so much more than simply not being sick. It's about getting a balance between physical, mental, emotional, cultural, and spiritual health. Health and healing are interwoven, which means that one cannot be separated from the other. The following presentation tries to understand and respect the cultural meaning of health and acknowledges and highlights that any psychological intervention can be helpful only if it aligns with the cultural values and beliefs of the recipient population. Now, let's imagine the story of a woman, Lina, in a remote community who is worried that her son is not meeting his milestones on time. So here is her journey. If there is a suspicion that Lina's child is on the spectrum, the evaluation team would refer to the formal diagnostic criteria of the DSM-5. And so, according to these criteria, an individual must exhibit persistent challenges in social communication and interaction across multiple settings, and also demonstrate restricted and repetitive patterns of behavior, interests, and activities. Further, symptoms must be present in the early developmental period and cause clinically significant impairment in social, occupational, or other important areas of functioning. These disturbances must not be better explained by intellectual disability or global developmental delay, but they may co-occur. However, the DSM is grounded in a Western framework, and therefore it may not align or be accepted by Indigenous populations, as it may conflict with their cultural values. Diagnostic and assessment tools currently used also lack cultural sensitivity. For example, some features of ASD, such as avoiding eye contact, may not be considered problematic in Indigenous cultures. This means that as ASD diagnosis in Indigenous people requires a nuanced understanding of the Indigenous culture, values, and way of life. Over the past 3 decades, ASD prevalence has risen due to broadened diagnostic criteria, improved reporting, greater awareness, earlier diagnosis, and enhanced access to services. Recent data indicate that 1 in 44 children in the United States and 1 in 160 children international has a diagnosis of ASD. However, while the prevalence of ASD worldwide has increased, the prevalence of ASD in Indigenous populations is largely unknown, with rates often assumed to be equal to the national average. In Australia, culture and language barriers and a lack of remote services may contribute to the underdiagnosis of ASD within the Indigenous population. In turn, this gap in knowledge may contribute to health inequities affecting Indigenous individuals and their caregivers. There are several empirically validated screening and diagnostic measures for ASD, and here I will report only a few. Autism screening involves brief assessments that determine the likelihood of a diagnosis across the lifespan. In toddlers, screening for autism involves the use of brief assessments such as the modified checklist for autism in toddlers and the screening tool for autism in toddlers. The Childhood Autism Spectrum Test is applicable to children and the Autism Spectrum Quotient adolescent version to adolescents, as the name implies. Lastly, the Autism Spectrum Quotient and the RITV Autism Asperger Diagnostic Scale, revised, are designed for adult populations. When screening results suggest risk of autism, people are typically referred for more comprehensive and diagnostic evaluations. Autism evaluation requires information from various sources, including caregivers, teachers, self-reports, and direct observations by a clinician. A diagnostic evaluation may include interviews and observational measures, but also developmental, intellectual, and adaptive skills assessment. However, these mainstream tools were all developed primarily within the Western cultural frameworks. At present, there is a lack of standardized and culturally specific questionnaires. To my knowledge, there are no widely used and standardized autism screening or diagnostic questionnaires specifically developed by and for diverse indigenous populations in countries like the US, Canada, Australia, or New Zealand. Why is this a problem? Because there is a potential for cultural bias, as mainstream tools may misinterpret culturally normative behaviors. For example, the MCHAT question, does your child point to show interest, may be misinterpreted as many Indigenous children use shared storytelling or group activities to express interest, not pointing. And language concepts within the tools, such as pretend play or other specific social cues, may not translate directly or hold the same meaning. Further, there is a lack of trust, as historical trauma and ongoing systemic inequities in the healthcare system create mistrust, making families less likely to engage with assessments using unfamiliar tools. And this leads to under-identification, with culturally inappropriate tools leading to indigenous autistic individuals being missed or diagnosed much later. And it also leads to over-identification, where conversely, cultural differences might be misinterpreted as pathology. For example, repetitive rocking could be a traditional soothing practice and not necessarily should be interpreted as stimming. Or limited imaginative play may reflect cultural emphasis on real-world skills over pretend play. Using culturally sensitive measures would alleviate these issues. As mentioned earlier, any effective approach must be community-driven, culturally grounded, and go beyond just translating or slightly modifying Western tools. It requires respecting indigenous knowledge systems and addressing the systemic barriers within the healthcare systems. Comorbidity, which is the presence of co-occurring disorders, is common in autistic individuals. Epidemiological studies reveal that more than 70% of autistic individuals have at least one co-occurring psychiatric condition, and more than 40% have two or more. Common comorbidities include anxiety disorders, ADHD, and depression. Further, according to large community-based studies, the rate of intellectual disability in autism is estimated to be around 35%. The potential for co-occurring conditions adds complexity to the autism assessment. There can be an overlap of symptoms, such as diminished eye contact and low social initiative, which are seen both in autism and depression. And social challenges, language difficulties, and sensory issues and attention problems can be both present in ASD and ADHD. Furthermore, diagnosis of psychiatric conditions such as anxiety, depression, or obsessive compulsive disorder often relies on self-report of internal experience, which can be more challenging for autistic individuals, especially those with intellectual disabilities and/or limited language. Accurate assessment of behavioral and psychological concerns in individuals with ASD is crucial, as it allows for specific and individualized treatment planning and management of additional symptoms, and in turn, it leads to optimal treatment outcomes. When making differential diagnoses between autism and other conditions, and when considering comorbid diagnosis, it is important to evaluate the trajectory of symptom development, that is, onset, duration, and course. Co-occurring conditions should be considered where there are symptoms present which are not explained by autism, when there are changes in functioning from baseline, or when the individual is not responding to interventions. Here is a paper published in 2020 by Chauchet et al. That aim to identify and evaluate psychosocial programs and resources for Indigenous people with ASD or other neurodevelopmental disorders and their caregivers. The authors emphasize that existing diagnostic and intervention frameworks based on Western medical models may not align with Indigenous values and experiences, contributing to underdiagnosis and service gaps. First, the authors conducted a systematic review following present guidelines. Peer-reviewed and grey literature were searched across 28 databases, using terms related to Indigenous populations, ASD, and psychosocial interventions. Articles were deemed eligible if they described an intervention, support, or initiative or strength-based therapy that had been developed and trialed, and which aimed to improve well-being in such communities, where for the purpose of this review, well-being was described as encompassing emotional well-being, and so feelings of positive effects such as happiness, hopefulness, life satisfaction, and quality of life, but also psychological well-being, involving positive functioning, self-acceptance, personal growth, resilience, and fulfillment, and social well-being, including connectedness, feeling valued by society, thriving in social relationship, but also enjoying spiritual health. Further, participants of the studies were Indigenous children, adolescents, and adults who displayed characteristics of or were diagnosed with ASD or any other neurodevelopmental disorder listed in the current or previous versions of the DSM. Further, the authors also compiled a catalog of other available psychosocial resources that didn't quite fit the PRISM criteria. Similar inclusion criteria as before were used to screen the resources. Only 7 studies met the inclusion criteria, reflecting the scarcity of culturally informed interventions. The identified resources varied in format, ranging from toolkits to programs and guides, and were often adapted from existing non-Indigenous materials. Few studies involved co-design with Indigenous communities, but limited evaluation data were available regarding effectiveness. However, the studies showed preliminary but positive outcomes associated with the implementation of these programs, including improvements in personal outcomes, for example, improved mood, self-esteem, relaxation, self-regulation, and executive functioning, but also improvements in social outcomes, for example, social skills and emotional awareness, and improvements in cognitive outcomes, such as concentration and communication outcomes. One study of relevance involved the ALER program and focused on improving self-regulation and executive functioning skills in primary school children in a remote Australian Aboriginal community. This small pilot study consisted of a 8-session weekly teacher-delivered self-regulation program in a remote community, which was characterized by a high prevalence of developmental impairment associated with FASD. The selection of this study actually reflects the scarcity of studies I was able to find, and so I wasn't even able to pick a specific study that focused on ASD, but this is the closest I found to what I was looking for. In this study, parents and caregivers and teachers of 25 children reported improved emotional regulation and executive functioning, with parents perceiving greater benefits. The program was adapted and implemented in collaboration with Aboriginal elders and community, school staff, and teachers. Teachers were trained to deliver the program and were supported during the delivery. Validated scales were used to gather data from teachers and parents at 3 different time points, and so at pre, post, and at a week follow-up from the intervention delivery. A measure of disruptive behavior was used as a proxy measure for emotion regulation. However, severe limitations are found in this study, including the small sample size, which included only 25 students. There was a very high attrition bias with up to 52 students dropping out of the study, um, and with all of these elements threatening the study validity. Next, the catalog of resources search yielded 11 articles, nine of which described resources that were developed and trialed in Australia. Identified resources varied in format again, including online workshops, web platforms, or Facebook groups. However, often these resources were characterized by limited evidence-based effectiveness, with only 3 out of 11 having been formally evaluated for effectiveness. All resources were free, but 6 relied on external funding and 9 required internet access, which of course limits accessibility in rural areas. A promising resource identified in the catalog is the Early Days Workshops, which was developed in conjunction with the Secretariat of National, Aboriginal and Islander Childcare and Early Days. It focuses on promoting development of young children on the autism spectrum. The format is hybrid with online workshops, accessible Australia-wide, and face-to-face workshops, which are organized locally. The target group is parents and caregivers of Indigenous children with ASD, and the workshops are focused on psychoeducation about autism, strategies to build resilience, guidance on accessing local assessment and post-diagnosis services. The workshops are delivered by early day staff in collaboration with Aboriginal communities to ensure cultural safety. These workshops have been formally evaluated through feedback from Aboriginal parents and childcare workers, making it one of the few evaluated and culturally adapted programs that are specific for Indigenous families of autistic children. Overall, while some culturally adapted resources exist, the reach and evidence base remain limited, highlighting a need for more evaluated, accessible, and sustainable support options for Indigenous autistic individuals and their caregivers. Further, the findings reveal a significant gap in culturally safe, co-designed psychosocial resources for Indigenous people with ASD. The authors of the article stressed the importance of incorporating Indigenous perspectives, cultural knowledge, and language into resource development, and called for greater collaboration with Indigenous communities, more rigorous evaluation of interventions, and systemic change to address barriers in diagnosis and support. Autism spectrum disorder in indigenous populations presents complex challenges that intersect with cultural identity, language barriers, and systemic inequities. A multidisciplinary approach bridges clinical expertise with indigenous knowledge systems to provide comprehensive and culturally safe care. This requires collaboration between psychologists to deliver culturally adapted assessments and interventions, but also speech pathologists with language assessments tailored to the first language and dialect of the recipients, occupational therapists to support daily living within kinship and community context, and crucially, it is paramount to involve Indigenous health workers and elders to culturally liaison, ensuring community trust. Effective models emphasize community-based co-design, where interventions are developed in partnership with Indigenous leaders. Integrated care systems combine clinical service with local support networks, using both telehealth and in-person delivery to overcome geographic barriers. Elders play a central role in guiding culturally appropriate communication and assessment methods. A multidisciplinary framework respects Indigenous worldviews by incorporating cultural practices into therapy, such as land-based learning or storytelling. Early intervention through coordinated teams leads to better long-term developmental outcomes. Unfortunately, implementing this model demands significant resources, including sustained funding, specialized training, and infrastructure for remote communities. To summarize, when assessing and treating ASD in Aboriginal and Torres Strait Islander populations, it is essential to consider a range of cultural, ethical, and developmental factors. Culturally, understanding Indigenous worldviews and way of life, kinship systems, and holistic concepts of health is critical. Without cultural adaptation, there is a risk of misdiagnosis, highlighting the need for culturally validated screening and diagnostic tools. Diversity and equity must also be acknowledged, as Aboriginal communities are heterogeneous, with variations in language, traditions, and rural versus urban contexts. Geographic isolation, systemic inequities, and limited access to specialists can create barriers that delay diagnosis and treatment. Ethical practice requires cultural safety, avoiding deficit-based interpretations, and ensuring community consultation, informed consent, and sensitivity to language and literacy differences. Safety considerations involve adopting trauma-informed care that recognizes intergenerational trauma and mistrust of health services, while fostering inclusive and supportive environments for children and families. Gender differences must be considered, as Aboriginal girls are at risk of underdiagnosis due to differing presentations and community gender roles. Age also plays a role, with challenges in early identification and the need for a lifespan approach that supports children, adolescents, and adults, particularly during transitions to independence and employment. Finally, treatment should integrate culturally relevant approaches such as play, storytelling, and connection to land, with Western therapies ensuring family and community involvement to create holistic, effective, and culturally meaningful care. And so, back to our case study. For a practitioner working with Lena and her child, this cultural context is not just background information, it is essential foundation for providing effective and respectful support. We must shift our perspective. As Scott Avery describes in his book, disability wasn't even a concept in Australia pre-colonization. He references some ancient footprints in western New South Wales, which showed a one-legged man participating in a hunt, symbolizing full inclusion in community life. Indeed, people were only valued for their responsibilities and roles. I will leave you with a question. What is the impact of using Western concepts for the overall well-being of Indigenous populations? Thank you for watching. Bye!